The title of the event is Together Ensuring Deserved Care for Every Liver Cancer Patient. And we are looking forward to hearing about some new interesting data on that during the day. And I'm sure we will have a fruitful discussion and insights. But first of all, let's start with some housekeeping rules. Please share the slides when you can. Okay, as you will see, your video and audio are disabled, but you can still write your question and comments in the Q&A feature. Someone will monitor them and ensure that they are addressed. The event is being recorded, and in a few days you will receive the event recordings with a link. So next slide, here is the agenda for today. We will have a welcome session and then a series of lectures from our distinguished speakers and experts in the field of liver cancer. And finally, we will have some time for questions from the audience. So without any further delay, I will give the floor to Zorana Maravic, the CEO of Digestive Cancer Europe, who will open this event. Zorana, the floor is yours.
Thank you, Mariana. Good morning, everyone, and thank you for attending this online event for Liver Cancer Awareness Month organized by DiCE. The aim of the event is to raise awareness on liver cancer, foster collaboration, share knowledge, and spark discussions in order to work together towards developing strategies to enhance the care and treatment of liver cancer patients. It is clear that we must unitedly take actions towards encouraging policymakers to put liver cancer high on their agenda. Otherwise, we will witness the further increase of the burden of liver cancer in the upcoming years. As I hope all of you know, DiCE is an umbrella organization of close to 40 national member organizations from across Europe, representing all digestive cancer patients, carers, those patients diagnosed with colorectal, gastric, liver, esophageal, pancreatic, and rare cancers. Our mission is to contribute to early diagnosis and decrease mortality from digestive cancers and to increase overall survival and quality of life. In the field of liver cancer, there are several unmet medical needs that DiCE aims to help address, as these lead to struggles that the liver cancer patient community is facing day after day. Importantly, early diagnosis of liver cancer is associated with significantly better chances of successful treatment, hence improvement survival rates and quality of life for patients. Despite the fact that populations at high risk of liver cancer are easily identifiable, there is no established screening program for liver cancer, nor is surveillance in at high-risk groups widely practiced. As later presentations will highlight, there is a burning need for addressing this across Europe, but also globally. To advocate for screening and early diagnosis, DiCE has united with the International Liver Cancer Association, ILCA, the European Association for the Study of the Liver, EASL, the European Liver Patient Association's ELPA, and the International Liver Cancer Movement, ILCM, and created 7 key messages that we have been sharing through our social media channels together with our partners this October. We passionately advocate for the access to best practice care for all liver cancer patients across Europe. Unfortunately, to date, there are significant socioeconomic and regional disparities in liver cancer care across different countries in Europe. To scope the extent of this issue and identify opportunities to advance access to best practice care for all patients, we have carried out an extensive research project to map the liver cancer treatment landscape across the EU. Based on the results, we have produced the Liver Cancer Index, an interactive map that highlights the liver cancer treatment landscape across the EU, and a PDF report of the list of advocacy points based on this index. And later from my colleague Lily, you will hear more about this research project, but also I invite you to visit our website and look for the map, but also you can see more information on our social media channels. Furthermore, throughout the whole year, but especially in the month of October, we are raising awareness about liver cancer and the importance of prevention, early diagnosis, and best practice care throughout our social media channel, newsletters, and website. Medical societies, patient organizations, and other stakeholders active in the field of liver cancer must all work together towards a future where all liver cancer patients receive the care that they deserve. Our goal is to create a collaborative environment where experts and stakeholders can identify and address the barriers faced by liver cancer patients. Through today's event, we hope to establish lasting collaborations and encourage the establishment of initiatives from the benefit of liver cancer patients. And to conclude, I strongly believe that we should not only speak about liver cancer today, but also in October, but also during the whole year, as liver cancer is a growing burden across Europe and globally, which we must address every single day in a united, collaborative manner. Thank you for coming to our event, and Mariana, I give the floor back to you.
Thank you, Zorana. Thank you for your message and for reminding us the importance of prevention and early detection, especially for liver cancer. And now it's my pleasure to welcome our second speaker, Dr. Lorenza Rimassa. She's a Deputy Director of the Medical Oncology Unit and Head of the Gastrointestinal Oncology Section at the Humanitas Cancer Care in Milan. And she's also Treasurer of the International Liver Cancer Association, ILCA. Please, Dr. Rimassa, the floor is yours.
Thank you for the nice introduction. Good morning to you all, and thank you, DiCE, for the kind invitation. As I said, October is a Liver Cancer Awareness Month, and I cannot agree more on the title of this event, Together is key, ensuring deserved care for every patient with liver cancer. I think Liver Cancer Awareness Month is a great opportunity to increase the awareness of liver cancer. However, as just said, we cannot think of liver cancer only in October. Hepatocellular carcinoma and cholangiocarcinoma are cancers that are frequently diagnosed at an advanced stage when therapeutic options are limited, and unfortunately the prognosis is still poor. So we must work on liver cancer not only in October, but during the whole year and always. We need to increase the awareness, and we need to continue to promote and support research to improve available treatment options and patient prognosis. Also, we must remember that liver cancer is not a single disease. There is hepatocellular carcinoma, HCC, that is the most frequent primary liver cancer and most frequently diagnosed in patients with chronic liver diseases. And there is cholangiocarcinoma, that is part of biliary tract cancer, that is the second most common primary liver cancer. Importantly, cholangiocarcinoma is a rare cancer, but its incidence is rapidly increasing in recent years, especially in countries with historically a low prevalence, like Europe, for instance. And for cholangiocarcinoma, the risk factors are not so well recognized, so the early diagnosis is even more difficult. Ideally, patients with liver cancer should be evaluated at a referral center or expert center at least once, in my opinion, to define the diagnostic and therapeutic pathway. Patients should be discussed at a multidisciplinary team meeting so that they can receive the optimal assessment and treatments and have the possibility also to be enrolled in clinical trials. In addition, for cholangiocarcinoma, we know that the molecular profiling is key to define systemic treatment options in the advanced setting. And unfortunately, too many patients still do not have access to the test. And this is another reason why patients should be evaluated at an expert center. Importantly, patients can and should receive standard treatment, the treatment in clinical practice, also at peripheral centers, at centers close to home, to avoid traveling too much. But the point is to have the indication of the best treatment option in the different best treatment option for the different stages of the disease. Another key point to me is represented by the collaboration, as mentioned, between patient advocacy groups or patient representatives, patient associations, and the scientific societies, both at the national and international level. And I do believe that together we can achieve better results. As an example of this collaboration is the ILCA, International Liver Cancer Association Advocacy Committee. Manon Allaire, who is part of this committee, will talk later on today at this event. In the same direction, patient advocacy groups should be included in the guideline writing committees and related meetings at national and international level. Unfortunately, this is not always the case, and we should work on improving this. Also, patient representatives should be involved in the process of approval and price negotiation of new therapeutic options, especially but not only new drugs, and international level, that is the EMA in Europe, and national level. And again, unfortunately, in some countries, this is not allowed or simply not considered, and we must work together to change this. Another important point is the involvement of patient advocacy groups or patient associations in treatment development process, not only for drugs, but also for other therapeutic options. This is done, for example, in the US, in the National Cancer Institute NCI task forces, where patient representatives have a regular position and comment and discuss trial proposals, and this is mandatory. Sometimes this is done by pharma companies, which involve patient representatives in the design of clinical trials, but not on a regular basis, and most often without a real opportunity to modify what has been already defined. So we must work also on this point. To conclude, I believe that for patients with liver cancer, and I mean hepatocellular carcinoma and cholangiocarcinoma, the collaboration between scientific societies, researchers, investigators, physicians, and patient groups is fundamental. All the stakeholders should be involved in multiple steps from the development to the approval of new treatments to ensure that all the patients may have access to them. Working together, we can meet our goals, increase the awareness of these diseases, ensure optimal care for every patient with liver cancer, and improve patient outcomes. Thank you so much for inviting me.
Thank you, Dr. Rimassa. Thank you for your message to remind us the importance of multidisciplinarity and collaboration. And now I will give the floor to Mr. Milan Mišković. He's a founder of EPAR Center Bitola in North Macedonia and director of the European Liver Patients Association, ELPA. Milan, the floor is yours.
Thank you very much for the kind words and for the introduction. Today, I would like to read some statement about what meaning for us Liver Cancer Month, but after the expose of Lorenza and Zoran, sometimes you can be without words. But what I like to try to emphasize now is how everything started and how ELPA president, ELPA governing board, like to thank you to all of you from the patient and scientific communities, somehow involved directly in all processes, how to emphasize the problem with liver cancer in the past and now. How ELPA started this kind of great initiative before 6-7 years, and step by step, all of you become our main stakeholders and partners to develop a patient scientific strong voice, how to change the policy level of activities at European level. This kind of movement, which already it's very strong at the European level, brings somehow light of the end of the tunnel. Why I'm saying this? This is excellent opportunity to see the development, development of the process between all of us, like one of the main stakeholders who like to try to change the landscape of liver cancer at Europe. I think liver cancer deserves the place among all other cancers. We mentioned a lot of times in the previous speeches from Lorenza and Zoran about the Liver Cancer Awareness Month. We know that October was Pink Month, but now we speak about liver. We are proud on that, and we are proud that we have so many friends and stakeholders who support this initiative. How this year we changed our, let's say, acting in the advocacy field, because we know after the COVID-19 was very difficult to act on European level face-to-face. But this year we changed that, and for the first time we organize different kind of activities. Besides of the social media support channels and everything what is going online, on different kind of roundtable discussions and every kind of awareness among us between patient advocacy and scientific community, we trying to change the landscape through our policy decision makers at European level. And ELPA organized different kind of events. Well, two of them were very important. That was directly organized in front of very important European institution like European Parliament. In front of them was one of the burning question open, which Zoran and Dr. Lorenzo mentioned, that is the early detection, the screening. And ELPA emphasized the needs of some kind of a pilot program, which is we're trying to call European Liver Screening Week, which giving a total advantage for us, like liver communities, to unite and to show that, this preventable liver cancer disease can be reduced in the future. We have a lot of activities which together we done in the past and we will doing in the future. How I see the approach for us is very important from this today meeting, because the patient and scientific strong voice, meaning for us change. What kind of change can bring on the policy level? How to advocate? How to prepare the people out of our frame to understand what's mean a liver cancer for them? What kind of liver cancer exists? What are the risk factors or one of the main causes for these diseases? Do these risk factors are preventable? How to stop them? We have a lot of challenges in front of us. Also equality, which DiCE mentioned, and the index, what they're doing with help with all of us. This is, let's open the door how to change the landscape of the quality of the treatments around Europe. But in the same time, we are also grateful for our international friends, which they established some kind of movement in the moment, which trying to change the landscape of liver cancer everywhere. This is giving a lot of opportunities for us how to unite international and European patient voice. But ELPA is very proud that it's one of the first organizations who start this October Liver Cancer Month, the Green Month, which now is recognized all European institutions. Thank you very much for the chance to today ELPA to present a small part of our activities. But with you, we are feeling that we are so big and great that we can change the landscape in the next period. Thank you very much.
Thank you, Milan. So as we are already a little right on time, I will introduce our next speaker, Dr. Peter Jaspen. He's a consultant hepatologist and clinical professor of hepatoepidemiology at Aarhus University Hospital in Denmark. He's also member of the Policy and Public Health Committee for the European Association for the Study of the Liver, EASL. So, Dr. Jaspen, the floor is yours.
Thank you very much, Mariana, and thank you for DiCE for giving me the opportunity to give this presentation entitled Early Diagnosis, Screening, Providing the Scientific Evidence. So as this figure shows, we have seen a marked increase in the incidence of liver cancer and in the mortality of liver cancer in the European Union over the past 30 years. And this is data from the so-called Global Burden of Disease studies commissioned by the WHO. And the marked increase in the incidence and in the mortality of liver cancer really shows that there is urgency here. We have to do something now. And it also shows that most of those who are diagnosed with liver cancer unfortunately die from liver cancer. Also, I should tell you now that, as you've already heard from Lorenza Rimasa, there are two main forms of liver cancer. One is hepatocellular carcinoma, which we usually call HCC, and then there is cholangiocarcinoma. My talk will deal with hepatocellular carcinoma only, and there will later be a talk on cholangiocarcinoma. We know that liver cirrhosis is really the #1 risk factor for HCC, in that 90% of patients who develop HCC have underlying liver cirrhosis. And liver cirrhosis in itself has a very poor prognosis, even among those who don't develop liver cancer. So we really see development of liver cirrhosis as a stepping stone from a healthy liver towards HCC. And that means that by preventing development of liver cirrhosis, we can prevent not only liver cirrhosis, but also HCC. And that's so very important to understand. And the major risk factors for liver cirrhosis are viral hepatitis types B and C, it's alcohol, and it's obesity. So this map shows the incidence of liver cancer in the European countries. And it's essentially to show you that there is a variation in the incidence of liver cancer across Europe. It's highest in the southern Europe and the Eastern Europe. And these geographic differences really reflect differences in the prevalence of viral hepatitis across Europe, again highlighting viral hepatitis as a step towards development to cirrhosis, and finally development of HCC. All right, so I've now told you a little about one way to reduce the number of Europeans who die from liver cancer, and that way is we have to prevent development of liver cirrhosis, and that requires policy interventions. The remainder of my talk will be about a different way to reduce the number of Europeans who die from HCC, and that way is early diagnosis. There are many different treatments of HCC, and you will hear more about those in other talks today. But we know for very sure that the chances of a cure are much better with an early diagnosis. Unfortunately, it's not so easy to make an early diagnosis because small HCCs do not cause any symptoms. So our answer is we have to do what we call HCC surveillance. And that essentially is repeated screening for HCC offered to our patients with liver cirrhosis. The screening is an ultrasound examination every 6 months. So it's important to be aware that HCC surveillance is not screening of everybody in the population. It's screening offered to patients with liver cirrhosis. All international guidelines recommend HCC surveillance to patients with liver cirrhosis. And this is despite the fact that there hasn't been a randomized study that has demonstrated that patients with cirrhosis who receive HCC surveillance live longer or better. And a randomized study has not been done in the past, and we now know that it will not be possible to ever do it. And that's because hepatologists like me are so convinced that HCC surveillance works in reducing mortality from HCC. So we're not really willing to run a randomized trial. And our patients are also convinced that HCC surveillance works. So nobody is really willing to do a randomized study at this point. So what evidence do we have? Well, we have done many studies that are so-called non-randomized studies, and one meta-analysis of 59 such studies followed nearly 150,000 patients with liver cirrhosis. And it reported that HCC surveillance led to earlier detection of HCC, and therefore it led to a higher chance of receiving curative treatment and being cured from HCC, again providing evidence that HCC surveillance does work. This figure represents another line of evidence in favor of HCC surveillance. It compares survival from HCC diagnosis between 3 countries. One is Japan, that's the red line, where survival for a patient with HCC is the best. Japan is characterized by full implementation of HCC surveillance. China, the green line by contrast, has the worst survival after HCC diagnosis, and that's because their patients are diagnosed late with HCC because they do not offer HCC surveillance to their population with cirrhosis. Europe is intermediate because, as I will show you in a minute, we do recommend HCC surveillance, but it's not really working as we are hoping that it will. Because this figure to your right shows a number of studies that have examined how many of our patients with cirrhosis do in fact receive the HCC surveillance that we think they should be offered. And you can see at the very bottom that overall, globally, it's only 26% of our patients who receive surveillance. I have highlighted in just below the middle the studies from Europe. And in Europe, we're doing a little better with 43%. But you can see in the horizontal lines above that there is large variation across countries. And really, 43% is not good enough. Some more detail was collected from a study from the United Kingdom. In this study, they followed 1,908 patients who had cirrhosis due to hepatitis C and were followed across 31 centers. And the graph shows the use of ultrasound screening tests as HCC surveillance in that population. And the stunning result is that only 9% of patients receive surveillance as recommended, so-called biannual surveillance, meaning 2 ultrasound screening examinations per year. 54% received 1 ultrasound examination per year, which is, you can say, halfway there, but it's not good enough. 28% received even less frequent ultrasound examination, and 9% received no ultrasound examinations at all. So I'm nearing the end of my talk, and this is just to show you that we are really hoping to make progress here. So EASL, which I represent, and its Policy and Public Health Committee, we are really hoping to strengthen the evidence for HCC surveillance, recognizing that we cannot do a randomized trial. We're still hoping for other lines of evidence that will strengthen the argument in favor of HCC surveillance. We believe strongly that more accurate data on the benefits and on the harms of HCC surveillance will increase participations in HCC surveillance. We also believe strongly in risk stratification, meaning that not all our patients with cirrhosis have the same risk of HCC. Some have a little lower risk and some have a much higher risk. And we think it's important to offer different screening regimens for these different types of cirrhosis patients. Maybe some are okay with just receiving 1 ultrasound examination per year, but maybe there are others who need 3 or 4 per year, or need an MRI examination instead of ultrasound. There is also globally a strong movement towards the development of new screening tests. In particular, if we had a blood-based screening test instead of ultrasound, it would be so much simpler to do HCC screening. Imagine that you can just go to your patient and take a blood test instead of having to take the patient to the radiology department so that they can do the ultrasound examination. Really, that is something we are very strongly hoping for. And then there is advocacy. We are very eager to talk to politicians and to patient organizations and to everybody, really, to raise awareness of HCC surveillance as a means to reduce mortality from HCC. So in conclusion, ladies and gentlemen, in the last 30 years, deaths from liver cancer have doubled in Europe. HCC is the commonest type of liver cancer, and 90% of those occur in patients with underlying liver cirrhosis. We know that HCC can be treated, but early diagnosis is critical for survival. And early diagnosis is possible through HCC surveillance. That means that we can save lives with surveillance for HCC. And EASL, DiCE, ELPA, ILCA, ILCM, and many other organizations are working together to strengthen the evidence for and the implementation of HCC surveillance. Thank you.
Thank you, Dr. Jespen, for the very strong message, and I'm sure, and we all hope that we will hear more about HCC surveillance in the next years. And now it's my pleasure to introduce our next speaker, Ms. Liv Rink. She's the chair of DiCE board and former member of the European Parliament, and also she's a cancer survivor. She will talk about the importance of deserved care for every liver cancer patient. Liv, the floor is yours.
Thank you. Good morning. My name is Liv Rink, like you already heard. As a former cancer patient, a former member of the European Parliament, and the current chair of Digestive Cancers Europe, it is my pleasure to speak on behalf of the organizations behind this meeting, as well as on the behalf of the digestive cancer patient community across Europe. As we have just reached the 5th anniversary of our organization, I would like to acknowledge all the work DiCE has been undertaking in the half decade to improve the outcomes and quality of life of digestive cancers across Europe. It is key that we all unite and work jointly to see fewer people suffering from liver cancer across Europe and globally. DiCE is grateful for the support of the two most influential medical associations in the field of liver cancer research, the International Liver Cancer Association, ILCA, and the European Association for the Study of the Liver, EASL. We would also like to thank the patient organizations that dedicate tremendous efforts into advocating for liver cancer patients across Europe, European Liver Patient Association, ELPA, and last but least of the International Liver Cancer Movement, ILCM, the first global liver cancer advocacy moment. Today, we all come together to increase awareness, promote early diagnosis and appropriate treatment of liver cancer. Liver cancer continues to be an increasing problem. It now ranks at the seventh leading cause of cancer-related deaths in Europe, with approximately 90,000 newly diagnosed citizens and approximately 80,000 citizens who sadly pass away from this disease every year. As a colorectal cancer survivor, I understand and sympathize with the physical challenges of the disease, while I also acknowledge the additional hurdles liver cancer patients across Europe are facing. Unlike for colorectal cancer, where there are established early detection programs available, as well as well-established treatment pathways that provide patients with several lines of treatment, liver cancer appears to be a neglected heavy burden. As a former MEP, I understand that there is still a lot left to be done to ensure that all cancer patients have access to the treatment and care they all deserve. I am proud of DiCE for, with the support of ELPA, EASL, ILCA, and ILCM, having taken a key step towards this goal by mapping the liver cancer treatment landscape across the EU this year in the framework of the Liver Cancer Index Research Project. In order to improve the chances of some highly quality healthcare services, understanding the availability of the liver cancer treatment, gather data that may limit access to the best care. It is our hope that with projects like the Liver Cancer Index, with today's event, as well as future Digestive Cancer Europe collaborative efforts, we will amplify the discussion towards real action in improving, first of all, screening and early diagnosis, second, treatment options and treatment accessibility, and ensuring the deserved care for all liver cancer patients across Europe. And as our motto says, preventing Europeans from becoming digestive cancer patients. Thank you for your attention and for being here with us. Now let us dive deeper into the topic of liver cancer treatment across Europe. Thank you.
Thank you, Liv. Thank you for your so needed speech. And now is my pleasure to introduce our next speaker, Dr. Maria Reig. She's the head of liver oncology unit at the Hospital Clínic of Barcelona in Spain, and she will introduce us to liver cancer treatment guidelines and approaches. Dr. Reig, the floor is yours.
Good morning, everybody. Thank you very much for the kind invitation. As you mentioned, I have the role of these 5 liver treatments in liver cancer treatment and the guidelines approach. I can try to move my slides, but just a second. I progress the control. This is not this works. Okay, before talking about treatment, I would like to emphasize the role of the prognosis. Since 1985, there are many proposals of staging patients and defining the prognosis of patients before giving the treatment. As you may know, the BCLC, as the department that I'm responsible, developed the BCLC guidance in 1999 and then was updated year by year. The last one was in 2022, but today we are in 2023 and there are also new things in our landscape. That's why this is like to emphasize that before selecting the treatment, we have to know exactly what is the prognosis of the patient. So the talk is about guidelines. However, I'd like to also mention that the ILCA, the American guidelines, the European Association have the guidelines, and the Asian Pacific also have the guidelines. There are also the ESMO guidelines, so there are many guidelines around the world. But this flexibility that we have at this day is a bit different as we have in the past, because as now we have more and more options, the physician have the responsibility to identify what is the best treatment for each patient. The guidance or the guidelines are the framework for deciding, but the responsibility is the tumor board, and that's why we update this part of the BCLC staging system. The main message here is the most important thing is what are the options that you have in your local level to select the best treatment for patients and try to work as we are working today for having more options around the world. In a specific point of guidance or guidelines, almost all countries have at least one reference to use or use the European, American, or Asian Pacific guidelines. As I'm from the BCLC, and the BCLC is almost represented in all of the guidelines that we have around the world, I will give you the view of the treatment based on this classification. The most important thing for selecting the treatment is define the tumor or the liver-related factors such as tumor burden, blood pressure, performance status, or liver function. Then we also have other important things that are comorbidities, treatment options in the different parts. All of these factors are prognostic factors based on the patient. However, we have to be responsible as a physician or doctors related to the liver cancer that the prognosis of patient is also based on the diagnosis that we are doing, the staging that we are doing, and the management of the patient. So at the end of the day, the prognosis of patient is factors related to the patient, but also factors related to the physician actions that it is management. And that's why before selecting the patient, we have to have these points in mind. So let's go specifically for the time of treatment. As you may know, the BCLC staging system have 5 stages based on the tumor burden, performance status, and liver function, and the proposal treatment, as we have here, based on the treatment that improve overall survival. However, in clinical practice, we are visiting patients, not CT scan or lab tests, and that's why we add this part that is clinical decision making. The treatment is based on the characteristic of patient, value of the patient, and the availability of treatment. That's why if you have a patient who are in the very early or early stage, we plan to give a treatment with the intention of cure, but it is not the case for any reason. We could consider treatments that could be treatment that improve overall survival, but they are not considered cured characteristics. The other important thing is in the middle of intermediate or advanced HCC, means patients who have HCC outside the liver, they are not candidates for local regional treatment. We have a lot of options here as a systemic therapy. However, nowadays we have more than one option in first-line treatment, but unfortunately, we do not have treatment beyond first-line treatment, and in this setting, clinical trials is the first option that we propose here at the BCLC. However, you could work or you could live in a place there are not clinical trials, and that's why we also add this part of the figure that is a red box for those treatments that we have data in terms of response, that we have treatment that's based on safety, but it's not feasible to demonstrate the benefit in terms of overall survival. So at the end of the day, all of these factors are the factors that we want to consider before we decide on the treatment. However, as a physician, a patient, or a caregiver, the main option is decide what is the best option for each patient. Generally speaking, as Lorenza Remasa mentioned at the beginning, patients with HCC are patients who also have liver disease, and 90% of them at least could have cirrhosis. So if for a patient with HCC, potential candidate for liver transplantation, this is the first option treatment that we have. And that's why when we visiting patient, our first question is, what is the profile of the patient? If the patient have a compensated cirrhosis, we go directly to the BCLC patient system and decide the treatment. However, if the patient presents a decompensated cirrhosis, our goal is try to define if the patient is candidate or not for liver transplantation, based on the radiology criteria and also the comorbidities. However, as you can see here, I showed 3 different patients, 92 years old with Alzheimer's, male 60 years old with a myocardial infarction 1 month ago, another patient without any comorbidity, same CT scan, same liver function, however, different profile. This is why we still comment and emphasize the role of the tumor board and the decision patient by patient. That's why in this case, this patient without comorbidities could be candidate for liver transplantation, but not the others. And the other important thing is the treatment of HCC. It is not a fixed treatment. We could consider the treatment as the first treatment based on the BCLC, or you could go beyond that due to treatment state migration. It is not possible to give the opportunity to receive the treatment that improves overall survival because the patient have any reason or due to the place that the patient is living. In this case, we could consider for the same patient in a different location, different treatment options. And again, this is responsibility, and this is my main measures. The responsibility it is for the physician, the regulatory actions, and all the awareness that we can do at local level to then put together the effort at international level. And again, the alternative treatment that are not approved now are the time for selecting for a specific patient what is the best option for each of them. The other important thing is if the patient receives a treatment or for any reason develop down station criteria, means I apply the treatment, the patient decreases the tumor volume and could be candidate for liver transplantation, this is something that we also need to consider. However, in the setting of systemic therapy, nowadays we have more and more data, but we don't still have information to use systemic therapy as down station criteria. The most frequent thing, unfortunately, is the untreated progression, means we give the treatment, but the patient develops progression. In this setting, again, our proposal and the majority of societies consider the same. We need to identify what is the systemic treatment that we could give to this patient. However, in the clinical trial setting, nowadays we have a lot of combination, local regional treatment plus systemic therapy, or different combination of systemic therapy. So to summarize my point, I believe that clinical guidelines at the end of the day are representing the clinical decision making. And at least when we did this update of the BCLC, we emphasize that we need to work in sharing decision making, but based on value-based care that recognize all of the characteristics of the patient. With that, I would like to thank again the invitation, and this is the last photo of the BCLC. But if you are interested in this connection between evidence-based and value-based care, I also will invite you to the BCLC update that we'll celebrate with many of you next month. Thank you very much.
Thank you, Dr. Rage. Thank you for navigating us through this very complex pathway that you are following every day to treating your patients. And now our next speaker is Dr. Manon Allaire. She's a doctor of medicine in La Pitié-Salpêtrière Hospital in Paris and member of the advocacy patient expert team for the International Liver Cancer Association, ILCA. She will introduce us to novel treatment approaches. Dr. Allaire, the floor is yours.
Thank you so much. Good morning, everybody. So it's a great pleasure for me to be here today and to represent ILCA, and especially the ILCA advocacy project which is leading by Bruno Sangro. And so today I will speak about the novel treatment approaches in HCC. So to start, I will follow with Maria's presentation with the BCLC classification. So as Maria just discussed, I think this classification is really interesting because it's quite simple to use and now quite well known all around the world. And this classification, allow us to propose the most adapted treatment for patients according to their comorbidity, their liver function, and also HCC features. So what is new in HCC for the last years? Well, the new treatment we had is for sure immunotherapy. And this new treatment allows to improve overall survival with quite good quality of life in patients mostly with advanced HCC, because for the moment, these immunotherapy drugs are mostly approved in patients with advanced HCC. But right now, what we are seeing is that we are trying to offer immunotherapy at early stages of the disease, and like intermediate or early HCC. And so one of the main goals for the moment and one of the main questions of the different clinical trials are, can we combine immunotherapy with local regional therapy? And indeed, this new approach seems really interesting. Why? Because when you are performing local regional therapy, such as TAFE, for example, chemoembolization or ablation, this will lead to necrosis and apoptosis of tumor cells. And we know that this will lead to the release of tumor antigens, but also specific cytokines, which may lead to pro-tumoral effects. So this could be maybe not so beneficial for treatment, but we also know that this will lead to an increased immune response. And so the idea is, why don't we do not add immunotherapy in this context in order to boost immune response and to improve treatment response for local regional therapy. So for the moment, this is still under investigation, but we already have some interesting data, such as these studies, for example, in which they propose to treat patients with immunotherapy, so tremelimumab, in combination with local regional therapy, such as ablation, chemoembolization. And what they observed that for the patient treated, the results were really interesting with better treatment response in these patients. And so what you have to know for the moment is that there is a lot of ongoing trial which combine local regional therapy, such as TAFE, but also at earlier stage with ablation, in order to know if this combination of treatment could be better than the usual actual therapy. So as Maria just said, clinical trials are really important right now, and this trial combining immunotherapy. So this is one of the aspects. And also, we just had the result of immunotherapy at adjuvant therapy, because this also is a new goal of research with the idea to propose immunotherapy at earlier stages with the attention to cure, as Maria just said before. And we recently had this positive result of this study. So this is quite new. It was published like some days ago. And the idea of this study was to propose immunotherapy after curative treatments such as surgery or ablation in patients identified with an high risk of recurrence of HCC. And as you can see here in this study, so they observed an higher recurrence-free survival in patients treated with immunotherapy after the treatment rather than patients who underwent surveillance. So this is also a new approaches and really new data that could be beneficial for treatment, but for the moment, we still need to have a bit more data regarding this result and maybe to identify more clearly the patient who will really benefit from this combination. And this will be for sure the reason of new trials which will be ongoing. So immunotherapy at earlier stages rather than advanced HCC, which is for the moment recommended. Another approach is also quite interesting right now, but Maria also discussed a bit about that, is the concept of the stages, because as we just discussed, finally, the patient will have his own history. And when he will present recurrences, for example, it might be a different story than the previous disease. And so we have to be quite careful and to propose migration therapy, as Maya just said. And one also of the new approaches is to consider downstaging, meaning that patients with more advanced disease, when they achieve response with local regional therapy or maybe systemic therapy, but for the moment we still don't know so much about it, but we have to think about the possibility to propose maybe better treatment and to propose a curative approach to these patients, such as liver transplantation and curative treatments. And here again, what is really important finally is the pluridisciplinary tumor board, because as Maya just said, we really need to discuss each patient according to the disease and where we are now with the disease. And maybe we can consider curative approaches in some specific situation. And to conclude with this, I will propose you to go to the ILCA website, because we are currently working on how to improve information to patients. And we will have dedicated pages regarding HCC and cholangiocarcinoma treatment with some videos and stuff, so it can be easier for patients to really understand the treatment for their care. So thanks a lot for the attention.
Thank you, Dr. Allaire. Thank you for sharing these new data and results with our audience. And now we are ready for our next speaker, Ms. Ellen Moment, founder and CEO of the AMMF cholangiocarcinoma charity in the UK. Please, Ms. Moment, the floor is yours.
Thank you. I'm hoping you're going to share my slides for me. Thank you. Thank you very much. And I hope I have control of them. Well, thank you for the kind invitation. I'm really grateful to DiCE for being invited to speak to everyone today. And my intention is to very briefly introduce AMMF and its work, and to give an overview of cholangiocarcinoma from AMMF's point of view. Now, when AMMF began in 2002, it was the world's first charity dedicated solely to cholangiocarcinoma. And today, we work across the UK, in Europe, and we collaborate globally. So some very quick basics. Cholangiocarcinoma is a primary liver cancer, and it's also known as bile duct cancer. It's one of the biliary tract cancers, and it's important to know there are 3 anatomical variations, and each one is now individually coded in ICD-11. The 3 anatomical variations: intrahepatic, when the cancer happens in the ducts inside the liver; hilar or perihilar, when it happens at the confluence of the main ducts, as they go down, become the common bile duct. And this is the most commonly occurring type seen clinically. And extrahepatic or distal, when it happens anywhere along that common bile duct from below the cystic duct. So these are the facts as we understand them. We know it's the 2nd most common primary liver cancer in the world. In 2019, it was the cause of death of 2,754 people in England alone. That's not the whole of the UK. and mortality parallels that incidence. And those facts are borne out by AMF's cholangiocarcinoma data project, which I'll come on to later. Very few inoperable patients will survive 1 year from diagnosis, a truly shocking statistic, and one that hasn't improved in decades. And although most data show this is a cancer affecting older people, at AMMF, we know this isn't a disease that occurs only at older age. The incidence is increasing year on year globally, and we do know that cholangiocarcinoma is a major problem in Southeast Asia. So a diagnosis of cholangiocarcinoma leaves many patients and their loved ones feeling the future is very uncertain. And when they contact AMMF, they're confused, feeling isolated and helpless, and they are afraid. Many will have received their diagnosis in a non-hepatobiliary specialist hospital, where through lack of knowledge and experience, they may have been told there's nothing that can be done for them. This can mean they miss the window of opportunity for surgery, currently the only potentially curative treatment there is, or they miss out on molecular profiling, as Lorenza said, becoming increasingly important. And so they miss possible targeted therapies, immunotherapy, and maybe clinical trials that they could be eligible for. AMMF's work to help the cholangiocarcinoma includes providing support and information in a number of ways. We have a comprehensive website which has information on every aspect of cholangiocarcinoma, including clinical trials. And to support those in Europe, we now have a European website which is currently available in 8 languages. And because all patients need to have access to reliable information in a level of language they can understand, as well as our websites, we have a growing number of informative resources, many in a variety of languages, and they're available in hard copy or to download. However, despite AMMF's years of work to raise awareness, there remains a lack of awareness and very little interest with those who have the power to move that dial and fully acknowledge this cancer. At AMMF, we concluded that the reason behind this was the lack of robust data. What we were seeing happening every day wasn't reflected in data, so was considered just anecdote and opinion, and that has no power to bring about change. So we decided we needed to find the data ourselves. And back in 2018, we started the process of commissioning our own national cholangiocarcinoma epidemiology work from Public Health England. And this work has looked at data from some 50,000 patients with biliary tract cancers between 2001 and 2018. And the findings were presented at AMMF's conference this year, and the presentation is available on AMMF's website. Now, some of the findings confirmed what we were already seeing. There's increasing incidence, and with this, we're rapidly approaching the stage when cholangiocarcinoma can no longer be considered rare, but it is a growing untargeted problem. It is affecting more younger people. Survival rate is appalling. And also, some of the findings we actually weren't aware of. Over half of patients received none of the treatments currently available for cholangiocarcinoma. And there's geographical variation in routes to diagnosis and treatment, and also in incidence. And this work has resulted in 3 papers, 1 just published and 2 others now going through the process. Earlier this summer, for the first time, the National Health Service in England published liver cancer data on their Get Data Out platform. And this clearly shows that in 2020, the 2 very different primary liver cancers, hepatocellular carcinoma and cholangiocarcinoma, had similar incidence. Hepatocellular carcinoma 2,792, and cholangiocarcinoma, 2,706. Yet, whenever liver cancer is mentioned, it is usually only hepatocellular carcinoma that is being referred to. Hepatocellular carcinoma gets the lion's share of the attention in just about every area, and health outcomes for those with cholangiocarcinoma currently lag well behind. So AMMF believes it's now time to rethink liver cancer. Our new campaign, launched at the start of October's Liver Cancer Awareness Month, is asking for more attention for cholangiocarcinoma, regionally and nationally, to enable earlier diagnosis and to increase access to treatments and reduce inequality. And although we've heard cholangiocarcinoma mentioned this morning, for too long, the term liver cancer has been synonymous with hepatocellular carcinoma, and cholangiocarcinoma has been the Cinderella, and we need to change that. The time has come to rethink liver cancer. So the findings of AMMF's data project underpin the Rethink Liver Cancer campaign and also our white paper, which addresses important misconceptions and now provides concrete evidence of the urgent need to improve how cholangiocarcinoma is recognized, is diagnosed and treated. And the white paper is available now to download from AMMF's website. So we have a long way to go to improve the future for those with cholangiocarcinoma. We do need to rethink liver cancer because cholangiocarcinoma is a primary liver cancer too, requiring far more attention. And every case of cholangiocarcinoma is someone who's deserving of the best possible advice, treatments and care. And that includes further opinions and molecular profiling. And reliable, accurate information should be available for all. And we believe all those with cholangiocarcinoma should receive their care from the most knowledgeable and experienced teams in the best facilities. And only then can patients be confident that their needs have been taken into account, that they're receiving the best advice, treatments and care, which is absolutely what they deserve. If you'd like to find out more about cholangio in the UK, across Europe and globally, and more about AMMF's work, please do save the date for AMMF's next international conference, 8th to 10th of May 2024, and all are very welcome. Thank you.
Thank you, Ellen. Thank you for the great work you are doing with your organization supporting patients. And then we are welcoming Ms. Lily Gundelach. She's a medical and scientific project coordinator at Digestive Cancer Europe, and she will present us her findings from the Liver Cancer Index. Lily, please, the floor is yours.
Thank you, Mariana. I will share my screen. All right, so today I would like to talk to all of you a bit about the Liver Cancer Index, as Mariana just mentioned, which is the extensive mapping project that DiCE has carried out this year to map the liver cancer treatment landscape across the EU. So as we now also heard from the previous speakers, liver cancer is the 9th most frequent cancer in Europe and the 7th most common cancer-related cause of death across Europe. And as we know, survival rates and quality of life are significantly higher when access to effective healthcare services is available to patients. Hence, us at DiCE believe that through a better understanding of country-by-country availability of liver cancer treatment and collaboratively using the gathered data to address any obstacle that may limit access to best practice care, we can ensure improved survival rates and improved quality of life for patients. And because of this, the aim of our project this year was to scope the availability of liver cancer treatment, in this case with a focus on hepatocellular carcinoma, across the EU and to create an interactive map highlighting the currently available treatments in each country. For this, we sought the input and experience of clinicians, patient organizations, and public health experts across the EU with the help of ELPA, ILCM, EASL, UEG, and ILCA. And using the Lime survey tool, we created an online mapping survey of 33 questions, which was distributed among the several stakeholders. Data analysis was carried out by members of DiCE, and the map was constructed. We also published a report that summarizes the key points out of the results. And I will now give you a short overview of our results. So first of all, a total of 223 people spanning 24 European member states participated in the survey. The distribution of participation among these 24 member states was relatively even, so on average, we had 8 to 9 responses per country. The results were analyzed manually by members of DiCE, and the online interactive map was constructed, for which the link is here. You can find this on our website if you navigate to the Liver Cancer Awareness Month page. And we also prepared a 2-page executive summary, which can also be downloaded from our page. And I will now give you a short summary of the results. However, I still recommend that you have a look at the map and the executive summary as well. But to say, sadly, our results reflect significant disparities in liver cancer treatment and care across the EU. And there are several major aspects where the member states do not meet evidence-based recommendations. Examples of this are that, as we heard previously, there are clinical practice guidelines from the European Society of Medical Oncology, ESMO, and the European Association for the Study of the Liver, EASL, which provide clear recommendations on best practice care, which are defined based on the Barcelona Clinic Liver Cancer BCLC staging system. However, we found that not all participants were familiar with these guidelines. 19 out of 24 member states have their own specific guidelines, but not all participants were aware of these either. On average, adherence to country-specific guidelines was between 50 and 75%. We believe that it's essential to increase awareness of guidelines and to ensure that they are adequately followed. We heard previously about the importance of multidisciplinary treatment. However, throughout our research, we found that this is not accessible to all liver cancer patients across the member states. Multidisciplinary treatment is widely recognized as a best practice care approach in cancer care management and is associated with improved survival rates. In 13 out of the 24 participating member states, there is no certification system for accrediting hospitals or clinics as expert centers for liver cancer. We encourage the member states to invest in and implement such certification systems, as data shows that quality of care and scientific rigor is significantly improved in case expert center certification is implemented. Our findings also suggest that liver transplants in liver cancer patients are not regularly performed across all member states. In most member states, the transplant waiting time is over 6 months. Accessibility to transplants for liver cancer patients should be improved, and living donor liver transplants is an option that could lead to improvement and better control over transplant availability. However, these transplants are not performed in 10 out of 24 participating member states. In 11 out of 24 member states, only some European Medicines Agency EMA-approved systemic therapies are accessible and fully reimbursed, meaning without cost to the patient. Liver cancer patients in advanced stages of their disease should have access to all EMA-approved systemic therapies. And finally, another Important, but often neglected aspect of patient outcomes is quality of life. And we found that in 22 out of 24 member states, quality of life questionnaires are not used, only in clinical trials. So in conclusion, our findings show significant disparities in liver cancer treatment and care across the EU, and also several areas where generally improvement would be necessary. And the disparities need to be addressed to provide access to best practice care to all patients. We encourage the EU and all member states to follow ESMO and EASL guidelines, as well as to, by building on ESMO and EASL guidelines, co-create unified harmonized guidelines to provide a clear and concise set of recommendations and define the standard for liver cancer care. These guidelines should also focus on quality of life, not just on overall survival, as a significant aspect of defining treatment success. And while several treatments are associated with long-term survival, as we now heard from Peter and in several other talks, the earlier liver cancer is detected, the better the patient's prognosis. And as we know, it is easy to infer who is at risk of developing liver cancer. Screening groups of people for liver cancer who are at high risk of developing this disease is recommended as a robust method for reducing mortality. Hence, liver cancer surveillance needs to be implemented in high-risk groups. Thank you.
Thank you, Lily. I invite you all to visit the map that you can find on the Digestive Cancer Europe website. The link has been shared in the chat. And also, as we are approaching to the last lecture, please share your question in the Q&A section. So our last speaker is Mr. Achim Kautz. She is the CEO of a non-profit project called Kautz 5GUG, and is also managing director of the International Liver Cancer Movement, ELCM. Today, he will talk about patient advocacy perspective in the liver cancer field. Please, Achim, the floor is yours.
Yeah, thank you very much. And thank you very much for the kind invitation. And it seems that I can give you kind of the summary of what has been already discussed today. And first of all, I think that is a key message here, what has been told. Early detection is key. And there is strong evidence and good practice that a holistic strategy for liver cancer, for both HCC and CCC, improves the outcomes. And I like to come back to what Peter has said right in the beginning to the example of Japan. And I like this example very much because in Japan, as you can see here on the curves, there is a decline of the mortality. And that is because there is a holistic strategy in place in Japan. And there was political will. It was a government who had listened carefully to the medical experts and the patient community, and they started end of the 19th a new strategy. And look to the curves of USA or Australia. They still go up, but in Japan, they go down. But even more attention I like to bring here is that in Japan, 76% of patients are in early stages diagnosed, the BCLC 0 to A stage. That means 3 out of 4 can be cured. And it's even more important, as we have heard, that if you have an early detection at an early stage, you have best chances. So, but what are the success parameters? It is, of course, to increase awareness of liver cancer in the medical community. And please do not forget here to involve the family doctor. It is, of course, to increase the awareness of liver cancer in the high at-risk community. And we know who are high at risk, and we have to start better communication to them that they are also empowered to be part of surveillance. Please use a broad use of simple and well-established diagnostic tools like the ultrasound. And of course, as we have heard from Lily, we need state-of-the-art treatment for all liver diseases across all countries. A robust vaccination program for all newborns and high-risk groups is also very successful. And of course, to implement the policies to prevent the transmission of viral hepatitis, to counteract chronic alcohol abuse, and of course, to encourage healthy lifestyles that prevents obesity and the metabolic syndrome, because MASH will be the next liver cancer driver. The ILCM expectation to the EU, quite simple. You have a BICA plan. You promote several cancers, but please, please, please include liver cancer very prominent into the BICA plan, because it's simple. And if you do this, you save many lives across Europe. Please encourage member states to improve the surveillance for HCC and CCC. It's simple. It's really to address, again, we can do something together against liver cancer. And please guarantee access to the state-of-the-art treatment for all European citizens. And finally, listen carefully of the recommendations of the liver cancer experts and the liver cancer community. And if you don't believe what we are saying, just read the World Health Organization Guide to Cancer. Thank you very much, and please join the movement, become a member, and be a driver for fighting against liver cancer. Thank you very much.
Thank you, Achim. So we have now a few minutes left for some questions. So the first question is for Peter. Are there any advancement towards developing blood-based diagnostic for liver cancer? And if yes, what is the bottleneck for this?
Yes, there is ongoing work aiming to identify blood-based screening tests. There are also biomarkers that have been identified to stratify patients with cirrhosis according to their risk of developing hepatocellular carcinoma. So I will say that, yes, there is very promising work ongoing. I don't think there really is a bottleneck. I think there is a lot of interesting work going on in this field. I think the main challenge is to demonstrate the effect of these blood-based biomarkers in detecting HCC and comparing it with alternative surveillance strategies such as the standard of care, which is ultrasound every 6 months. So I think the field is moving ahead. We can all hope that it will move faster than it really is, but it is moving.
Thank you. Thank you. And then we have another question for Lily. Miss Diane Landerbach wrote in the chat, thank you so much for this fantastic work, Lily. This provides very important evidence. Would there be an option to do a second wave collecting information on surveillance implemented at country level?
I think that's actually also a very good idea. And either way, what I didn't mention, but what's also important about the Liver Cancer Index, first of all, is that this will be an ongoing and live project, since we are focusing there on treatment, which is something that is continuously evolving. And like I said, we have data from 24 member states, meaning that we're still missing 3, and we would like to fill these data gaps. So for that, there is also the initiative to continue working on this. And I think carrying out similar research projects focusing on diagnosis surveillance would also be very important. And I hope DiCE can also participate in this in the future.
Thank you, Lily. And now we have a question for all the speakers. What can we all do to reduce the prevalence of modifiable risk factors like alcohol and cigarette consumption across Europe? I don't know if...
Perhaps if I can start, so because I'm quite familiar with EU affairs. So there are a lot of programs, but I guess what needs to be considered is that within these programs, of course, it is sometimes forgotten the impact of alcohol and cigarettes to liver diseases. And that is something that needs to be rephrased so that also from this perspective, both factors are worked on. But I guess, Peter, your efforts from EASL are quite closer to my knowledge.
Yes, so one thing we have done recently at EASL is to use a so-called microsimulation model to examine the number of patients with chronic liver disease and with liver cancer who could be spared from their liver cancer and or their chronic liver disease if politicians introduced what we call minimum unit pricing, which is a policy targeting alcohol consumption because it sets a minimum price for a unit of alcohol if you go and buy it. So we know from other studies that minimum unit pricing works. It's a policy initiative that has now been shown to reduce alcohol consumption in the population. And we show through this microsimulation study that there are downstream positive effects to reducing alcohol consumption in that reduced alcohol consumption leads to fewer patients with chronic liver disease and cirrhosis, and also fewer patients with liver cancer. So that is one way to demonstrate it. And this is all part of what we call the HEPA Health 2 study, which has been launched on EASL's website and will soon be available through the scientific literature. Thanks.
I think that Maria also wants to comment on this, and then Milan.
Yes, I believe that the key thing is see the patient as a whole. And I believe that the area that and I know that many of you are also working, is the stigma for people who are smoking, for the people who are drinking, because before having this data, understanding the environment for this situation, I believe that it's not feasible to apply because everybody have a stigma, despite of the fact that we don't want to have it. So my proposal or point that to rise here is to add this point as a strong point in the decision.
Thank you, Maria. Milan, you want to add something?
Was connected with the stigma, of course, because Maria suddenly say the same. But what I like to mention, which is very important, we are speaking about liver disease and connection with some risk factors and everything. But what we are missing and what is the biggest challenges for us, like a patient community, when we like to emphasize the problem about liver cancer, we notice that out of the frame between the patient expert communities and the scientific community, when we approach to, beside the stigma who exists, which Maria mentioned and everything, the liver like an organ, that is a huge burden for us. Every time when we speak about hepatocellular carcinoma, cholangiocarcinoma, MASH, hepatitis, the question is how we connecting with the organ liver. That means we need to address in the same time double challenge. How I notice every time emphasize that something happened with your organ. That means the liver. A liver has a problem, different kind of approaches. And we need to somehow put on the higher stage the liver like an organ. After that, it's coming all the consequences and the diseases and problems with the liver. Sorry, this is we noticed the past couple of 2 years.
Thank you for this reflection. And then we have a question directly from one of our panelists, Ellen. She would like to ask all the panelists how they think the rising incidence of cholangiocarcinoma should be addressed across Europe. Surveillance is not appropriate and risk factors are very different to HCC, so lifestyle changes may not help. Who wants to address this question?
So maybe I can go first. First, I would like to say that I fully agree with what Helen Mormont says in her question. One of the main challenges is for cholangiocarcinoma that we don't have such a well-defined risk populations as we do for HCC. So screening is not really, at this point, I would say, a very strong way forward, because still cholangiocarcinoma, even though it's getting more common, it's still a rare cancer. So you would have to screen many people to find one cancer. And although we know some risk factors, for instance, patients with liver cirrhosis, they are also at increased risk of cholangiocarcinoma, but their patients with cirrhosis still have a relatively low risk of cholangiocarcinoma. So screening is really, in my view, not an option at this point. So I think we have to study harder. I mean, we have to look harder for risk factors. And my group is currently doing a project here in Denmark where we try to understand and describe the time trends and the incidence of cholangiocarcinoma, because I fully agree that there is a deep lack of knowledge with respect to risk factors for cholangiocarcinoma.
Thank you. We have another question from one patient advocate, Lasma Nicolaise from Onco Alliance in Latvia. She said, if I'm not mistaken, there is some evidence that type 2 diabetes is also a risk factor for developing liver cancer. What is the latest evidence, and is there any hope that these patients could be included in liver cancer surveillance in the future?
You want I can start? I believe that the most important thing.
You're on mute, Maria.
Now?
Yeah.
Okay. So the point of diabetes is every time in the discussion, if we take into consideration the number of patients that we have here, at least in our unit, we have the number, 50% of them are diabetics. So that means it is the diabetes, the relation with HCC, or it is the comorbidity that the patient has because they are also at the hypertension and so on. I fully agree with the comment that we need to have more data about that and understanding what is the real link, if it's really diabetes or the metabolic syndrome that the patient have as a whole. And it is still, from my point of view, an unmet need.
Thank you, Maria. And I would like to ask a last question. Recently, we have been working a lot on early age onset digestive cancer. I would like to know from you panelists if this is something that you are also observing in liver cancer, that the age of patients is decreasing across Europe. Lorenza?
Yes, it's a really important point, especially for cholangiocarcinoma. We are seeing not only an increase in incidence, as already mentioned by Helen and by myself, but also an increasing incidence in young people. The reasons, the causes are not well defined. So there are ongoing studies to try to understand why and to try to address also this need. But we have already discussed that the surveillance of the screen is difficult in the general population. It's even more difficult in young patients, but we have to think of a cholangiocarcinoma even in young people, sorry, not patients, before the diagnosis, if they have some symptoms that can can make you suspect for something wrong. But anyway, yes, the incidence in young people is increasing.
Thank you for your answer. Thank you all the speakers and the panelists to participate to this event. Thank you for the attendees. And as I said, you will receive the link with the recording of this event in the next few days. And so I think that we can close here this event. Thank you, everyone, and have a nice afternoon.